Right. Good morning, everyone. So my name is Whitney Isola. I am the co-founder of OncoPower, which is a digital health platform that's geared towards oncology care and really connecting patients and physicians and building meaningful digital health tools that sort of simplify the entire care experience for patients. So we have with us today Dr. Kansani. I'm going to call her Dr. T because I've been struggling a little bit with her name this morning. And so Dr. T is a medical oncologist. She's been practicing for over 20 years and has been specializing in breast cancer treatment for the past 12 years or so. She is board certified in internal medicine, hematology, and medical oncology. She earned her medical degree from Muhammad University in Morocco, and she completed an internal medicine residency at Englewood Hospital in New Jersey, which is an affiliate of Mount Sinai School of Medicine, and then a fellowship in hematology and oncology at Montefiore in the Bronx. She is a medical oncologist with Cancer Treatment Centers of America in Chicago. And thank you for joining us today, Dr. T. So you want to tell us a little bit more about yourself and what drew you towards oncology care?
Thank you for having me. I think you've already said enough about me. I'd like to go ahead and start answering the questions.
Okay.
In the chat room, there are a couple of questions I'd like to start with, and I have another one on my email. So there is a woman who shared with us her story and asked about monitoring after diagnosis of breast cancer. This woman had stage 3 triple negative breast cancer on the right side and another stage 3 ER positive HER2 negative on the left side. She had bilateral mastectomies and she had her ovaries removed. I do not have information about the genetics. So Janet, if you're there, and could you confirm whether or not you've had genetic testing? But her question is specific about how to be monitored. Her doctor told her that it's just follow-up visits and checking up on the symptoms and the exams, and no scans or testing are necessary. So I want to thank Janet. And so of course somebody who's had 2 sides breast cancer, bilateral breast cancer at 2 separate times or at the same time, first thing is genetic testing. This is not hereditary breast cancer. Janet said she is BRCA1 positive. So very important. So that's the reason why for Janet to have had both the breast removed and the ovaries removed. Monitoring, if you go by the guidelines and by the standard of care, there is no recommendation to do imaging studies. I think examination, talking to our patients about any symptoms from head to toe, any headache, shortness of breath, cough, pain, any new lumps and bumps that would lead us to do full workup or biopsies or scans. But without any symptoms, there is no standard of any imaging studies or any specific blood work. That being said, we're very, very cautious in our stage 3 patients, more so than our stage 1s or 2s, because the high.
There was only one.
I'm sorry, can you say that again? Did somebody ask anything?
I think somebody was just muting themselves. You can keep going. Yeah.
Okay. So, excuse me. However, we are very cautious every time there is any new symptom. So I tell my patients if I can only order scans if there is a symptom that requires a new scan. But I'm quick at doing imaging studies on my patients I'm concerned about. Sometimes it serves us as reassurance, but it's not really a standard to do it on a routine basis, only as needed based on symptoms. There are some very new things in the world of monitoring, but it's really early. There are some studies that are going on and some that are already published in the literature, but it's not standard again. I'm just mentioning it since it's new. It's using circulating tumor DNA for monitoring for recurrence. We still don't know how to use the test very well and what to do with the results, but I just wanted to mention it as an option in case Janet has heard of it and she was inquiring specifically about that. So in summary, no imaging unless guided by the clinical picture. Anything in the symptoms or anything in the physical exam would be quick in doing monitoring. Now, in my BRCA1 positive or BRCA2 positive or any hereditary breast cancer patients, because the mastectomies do not really take every single breast cell in the chest, and sometimes there is residual breast tissue, almost always there is some breast tissue. And anybody with genetic cancer, I still monitor the breasts. After mastectomies, mammograms are not helpful, but MRIs of the chest, I recommend them to my BRCA positive patients because of the potential new primary cancers in the chest, whether it's a recurrence of the old cancer in the same area or an outside of that. In the residual breast tissue, there is a risk of having new breast cancers in the breast despite bilateral mastectomies, and breast examinations are continued. And I do occasional MRIs if I'm able to obtain it in my patients with mastectomies and BRCA positivity. Another question was from Jessica, I believe. And then there was a question about whether the HER2 low, are we having a new medication for it? There is a new medication called HER2, which is a chemotherapy that's targeted by an antibody straight to the HER2 positive cells, but it showed some benefit even in patients who have HER2 low, meaning 1+ or 2+. So today, the definitions of HER2 positive disease is either somebody who has a HER2 3+ by immunohistochemical, meaning when they look in the microscope with a stain and they find 3+ HER2, that's definitively positive, or if it's 2+, which is considered intermediate, and then confirmed by a FISH test. I know that a lot of breast cancer patients are familiar with this terminology. So if there is a positive, the standard of care is to do HER2 targeted therapies, and there are many options now. But if they are considered negative by the standard, 1+ and 2+ are not really zero. There's still some HER2 expression. So there's studies trying to explore the benefit of this new medication called Enhertu in the HER2 low, and there's some hints of good activity in that setting in breast cancer. It's not really so far completely standard of care in HER2 low patients. Definitely not in the early stage. In metastatic setting, I believe it will become a new standard, and this category of HER2 low, it's going to become a separate category of breast cancer that would be addressed, not just as a negative HER2, but a HER2 low, and potentially benefits from specific HER2 targeted agents, just not standard of care yet. Stay tuned. Next question. Yes. There was another one. I had a person send an email ahead of time. Well, there was one here that's I'm really interested in from Jessica also about the latest FDA approval of Verzenio for early high-risk breast cancer. As a summary, Verzenio has been approved for a long time, 5 years now or so, for stage 4 or metastatic breast cancer, and it showed incredible activity in synergy with estrogen receptor blockers or with fulvestrant or aromatase inhibitors. Any hormone blockers plus Verzenio had showed very good activity in metastatic breast cancer. So every time there is a good activity in stage 4, the researchers try to bring it early on in stage 1 to stage 3 breast cancer, meaning given it with the intention to increase how many patients we cure of breast cancer and prevent them from becoming metastatic, which is always the goal. It had shown that in combination with aromatase inhibitors or tamoxifen, given for the first 2 years of the adjuvant endocrine therapy, it showed a substantial benefit, and it just got an FDA approval. Meaning our patients who traditionally would get surgery, followed by chemo, followed by radiation, followed by a pill for 5 years, will be getting 2 pills for the first 2 years, and then just continue the 1 pill for 5 years and sometimes 10 years. So I am very excited about this. I have been using it in my very high risk patients, just as the study has been published or talked about in ESMO this year. So I've had a few patients on whom I used it even a little bit before the FDA approval, and I'm very happy to see that it is approved for those patients. Some of these estrogen receptor positive cancers are very difficult to treat because even though we use chemotherapy, chemotherapy is not as beneficial as it is in some of the triple negative or the HER2 positive breast cancer. So we feel like there was a gap in really helping those patients achieve more cures. And I think this is really another step forward in combination with all the modalities to increase the cures of ER positive breast cancer. Verzenio is overall tolerable. Occasionally, at first, there are some issues with diarrhea, but I tend to start it a little bit slow. I just do 1 pill a day for the first few days, make sure there's no severe diarrhea, and go up. And we usually manage those side effects easily with frequent use of Imodium from the over-the-counter and good counseling. It can also cause some decrease in the blood count, which is typically not a dangerous thing. Most patients tolerate that without any risk of infections. It requires monitoring of the blood work. It can cause some fatigue, but overall, we believe that the benefit outweighs the risks. Somebody asked a question about anal cancer. Is it curable? And it usually is, depends on the stage, but there's very high cure rates for early stage anal cancer. And then there was an email. Let's go back to, there's a question about a woman who really broke my heart because she has had a history of ductal carcinoma in situ, so which is a really good prognosis, really excellent prognosis. It's also called stage 0 breast cancer. That's cancer cells inside the duct have not had a chance to break through the membrane and access the blood vessels and the risk of metastasizing. So it's still just localized, and typically it's cured with localized treatments. This woman had lumpectomy, meaning just excision of the lump plus radiation, standard of care for carcinoma in situ. But typically in those who have carcinoma in situ and they were hormone receptor positive, estrogen receptor positive, we usually recommend a pill called tamoxifen to prevent new invasive cancers in the same breast or in the contralateral breast. So I want to reassure, I think that was Veronique, that the DCIS is really a very good prognosis, and the cure rates with just the surgery and the radiation therapy are very high. The risk of recurrence of DCIS is about 15 to 20% based on the grade and other features, the size and all of it. It's not super high. The risk of having any breast cancer in all of us women is 12%. So it's slightly higher in women who have had DCIS before. So tamoxifen has been tried to reduce that risk, and it is successful in reducing the risk of invasive cancer in the same breast that already had it and in the contralateral breast, the other side. But it has not shown any benefit in survival. It didn't really help people live longer by taking tamoxifen. So that what it means is we're watching these patients carefully, so we're able to catch any type of recurrence, whether it's also in situ or invasive, before it causes any metastases or issues. And therefore, it is not necessarily offered to every single person. We like to offer treatments to our patients that are going to help them live longer. So when there's something that does not increase survival, the use of it is not necessarily completely standard on every single person, and it's used on case by case. Now, definitely in a person who has significant side effects. The reason I said my heart breaks for her is because she has severe migraines that has really impacted her quality of life. She is incapable to have to work or to function, and tamoxifen is known to increase the risk of migraines in somebody who has a predisposition. So Veronique is worried, so she's kind of, I'm scared to stop it because my doctor told me it's going to reduce my risk by about 50% of having another event, but at the same time I'm suffering. Again, here is to really reassure you that DCIS has very good prognosis, and with close monitoring, it's okay to not take tamoxifen and monitor, because it's impossible to live in that way. No alternatives to tamoxifen. There's been a study showing that if you, in postmenopausal women, if you use aromatase inhibitors, anastrozole or arimidex, it was at least as beneficial, if not slightly better than tamoxifen, in achieving the same goals, meaning reduction of having a recurrence in the same breast or a contralateral breast. Now, if you're not postmenopausal, there is a strategy besides removing the ovaries that can help put a patient into a menopause, which is an injection that suppresses the ovaries, which is temporary, not a permanent as removing them surgically. It can be given every 4 weeks, and it can allow this person to still take the preventative medication to prevent new events, but still hopefully not struggle with migraines. It could be that the migraines are related to just estrogen deprivation, and it may still happen with the other treatments. However, I've had some successes with switching from tamoxifen to a combination of ovarian suppression and aromatase inhibitors and not having recurrence of the migraines, or at least it could be better. The other option, which is always there, is do not use anything at all, just close monitoring with mammograms, physical exams. And if any recurrence happens, then we would pick up early and we will again operate on time. Next question. Going for a double mastectomy and reconstruction on Monday. BRCA positive. I don't know if there is a question. And then someone said, have you heard of ERSO? ERSO? I didn't understand that one either. Please clarify and add some more information. Stage. Okay, I have a new question, Joyce. I'm a stage 4 ER/PR positive and HER2 negative, diagnosed de novo in 2008, been on Femara letrozole since. Femara is the same as letrozole. CT scan every 6 months. I fear that I'm running in borrowed time because we all know someday it will come back. Would you suggest anything to be proactive? Thank you. You know, ER positive, PR positive, HER2 negative breast cancer can have some indolent course sometimes, meaning it can be slow progressing or stable for a long time. It can go in a dormant stage when the doctor performs scans after scans and there is no evidence of disease. This is very good news. And it's when we have those patients, we are very glad to take care of them because we get to see them have a very normal life despite the stage 4 cancer. So this is not so unusual to continue to enjoy as normal life as possible on the treatment, same treatments for a very long time. I do want to make sure that we monitor our patients very, very closely. At the time when there was the diagnosis, just starting an aromatase inhibitor was the standard of care at that time in all postmenopausal women. About 6 years ago, adding CDK4/6 inhibitors has become the standard of care. However, in somebody who's already benefiting and having no significant progression of their cancer, I don't see a reason to change anything at this time. We have this basket of options that we like to use very wisely and carefully so we can extend the options as long as we can. So even though we have available new options, there's no reason to use them up if the current treatment is working well. Sometimes I do combine CT scans with bone scans because sometimes the combination of the two can be more accurate in detecting lesions in the bone. Also, occasionally I can do a PET scan. That can also be a test to make sure we're not missing if you have any concerns about missing something. But if clinically on the laboratory tests and the studies, there is no evidence of progression of the cancer, I would not change anything at this time.
While Dr. T tees up the next question, there was a sort of a question adjacent to what we're talking about regarding, it was the same person that asked about the curability of anal cancer. They asked about programs with no insurance. And I just want to direct that user onto oncopower.org. Join our community and pose it there, because there's really a ton of resources in terms of people that have gone through exactly what you're going through, and we will help you find exactly what it is that you need for support.
Amanda asks us a general question, I appreciate very much. When are aromatase inhibitors used and what is their purpose? So aromatase inhibitors are a type of estrogen deprivation therapy. So this, typically there are different groups of the way we treat estrogen-driven breast cancer. So estrogen-driven breast cancer is really the majority of all breast cancers. 2/3 or so are estrogen-driven, meaning the cancer cells have these estrogen receptors that are driving the growth of the cancer, and we use that feature to target the treatment and kill the cancer cells. We have an option, the traditional oldest treatment we have, the oldest targeted therapy really is tamoxifen, which blocks the receptors of the estrogen in some of the tissues. It's really a partial agonist of the receptors or a modulator of the receptors. And then that is really something that works on breast cancer, whether the woman is menopausal or not, because it doesn't really do anything to the production. It works with the receptors peripherally. And then after that, we had the aromatase inhibitors. Now I think they've been since the 90s. And what they do is they use the production, they work on the production of estrogen that happens outside of the ovaries. So the main producer of estrogen are the ovaries in premenopausal women. After menopause, when the ovaries don't make any more estrogen, I like to tell my patients, we don't really turn into men. We still have estrogen in our body, and it is produced in some precursors of estrogen are produced in the adrenal gland, and they are transformed into estrogen using this enzyme called aromatase. So by inhibiting that enzyme, we prevent the production, we stop the production of estrogen that's driven by the adrenal glands. And that transformation of the precursors of estrogen to estrogen via this enzyme happen in multiple tissues of the body, sometimes, for example, in the liver, in some of the fatty tissue, in peripheral tissues. So it's an enzyme that helps producing estrogen in the body in postmenopausal women. We block that enzyme, therefore we block that estrogen feed to the cancer. It is used in early breast cancer, meaning between stage 1 and stage 3, after having surgery as a prevention of a recurrence. This is part of the treatment. It has really improved the prognosis substantially, because if there are any microscopic cells that have survived in the body, it allows them to go into a dormant state or completely kill them. So it really is a big success in increasing cure rates of early stage ER positive breast cancer. It is also the main treatment that we start in most of our patients with ER positive breast cancer that has already metastasized or stage 4. And it can be used either alone, but in stage 4, they are now used in conjunction with the CDK4/6 inhibitors, and there are 3 of them out there. and the doctors and the patient decide together on which one to use. And the combination really can be very successful in the initial treatments of all stage 4 patients. I'm going to go look for another question. What are pros and cons for HER2 3+ to get hysterectomy? Should this be done as preventive for recurrence? Angie, really the association between a hysterectomy, and I'm assuming that it's a total hysterectomy, which has the intention to really remove the ovaries, is typically a treatment that is suggested in estrogen-positive breast cancer as part of the treatment, or it could be a risk reduction strategy in women who have a high risk of hereditary mutation that can increase the risk of ovarian cancer or uterine cancer. In that situation, we ask our patients to get a hysterectomy. But in estrogen, it's an indication for estrogen receptor positive patients to treat them, because if we put them into a menopausal state by removing the ovaries, we can have them receive aromatase inhibitors as opposed to using tamoxifen. And that's because the combination of menopause plus aromatase inhibitors is slightly more effective than tamoxifen alone in those patients. But I do not see the reason to remove the ovaries in an estrogen negative breast cancer and in a patient who does not have hereditary mutation. So I'm not sure if the question was intended to say ER positive or HER2. She said HER2 3+. There must be some missing information that could justify why her doctors are recommending hysterectomy or why she's considering it. But with just that information, it's not possible to comment. Monica, you've been diagnosed with invasive ductal carcinoma grade 2, estrogen positive. So this is invasive cancer grade, no, skipped grade 2. Hysterectomy about 5 years ago. Estrogen positive, but they left my ovaries. Would it be recommended to have my ovaries removed now that I'm 59 years old? Okay. So I am 5 years ago, Monica was 54 years old, which means already potentially postmenopausal. I do not know if Monica was recommended a hysterectomy because of any concerns about a genetic condition that can increase the risk of other cancers. Sometimes doctors will recommend hysterectomies if somebody is on tamoxifen, because tamoxifen can increase the risk of cancer of the uterus. And if a person is on tamoxifen, if there is a risk, if there is bleeding or thickness in the lining of the uterus, sometimes a hysterectomy is performed to prevent the risk of cancer of the uterus. Because here the ovaries were remaining in place, which means we were not worried about the ovaries in terms of production of estrogen because she was already postmenopausal. I do not see any value to remove the ovaries now in the absence of any hereditary condition that increases the risk of ovarian cancer, because the ovaries are not responsible for making estrogen at this time. New question. I have MMT ovarian cancer, that mixed Malarian tumor ovarian cancer, who is BRCA2 positive. What would be a recommendation for double mastectomy for preventative treatment, Tammy? BRCA2 positive breast cancer is a high risk of having new breast cancers, even in somebody who never had it before. Between BRCA1 and BRCA2, the risk of having breast cancer can be between 30 and up to 80%, BRCA2 a little bit less than BRCA1. So it's high enough that preventative surgery is highly recommended. Then the recommendation usually depends on if the person has ovarian cancer already. What is the stage of the cancer? Is it cured with surgery or having high chances of cure with surgery with or without chemo, or is it an advanced ovarian cancer, in which case the focus is to treat that ovarian cancer as opposed to preventing new cancers? Assuming that the ovarian cancer was early stage and it was treated with surgery and all the necessary treatments, and the person has a very good prognosis, it would be highly recommended to do preventative surgeries for the breast to prevent any new breast cancers in a BRCA positive patient. Do you know of any medications to prevent reoccurrence in people with genetic marker for Lynch syndrome? So Lynch syndrome is a genetic condition that increases the risk of multiple cancers. The highest ones are colon cancer and uterine cancer of the endometrium or the uterus. It is the main prevention in patients with Lynch syndrome is to do surgeries, preventative surgeries, meaning removing subtotal colectomies and removing the uterus preventively. There is no specific medication, oral medication or intravenous medication or no chemical that would help prevent recurrence that's unique to the Lynch syndrome, but their cancers should be prevented and treated similar to other cancers, whether they're Lynch or not. For example, if a person with Lynch has a cancer of the uterus, then that person would be treated with the same treatments that other patients with cancer of the uterus would have had. And if somebody had a colon cancer, it's the same thing. If somebody with Lynch syndrome have had breast cancer, which I have seen, they also should be treated in a very similar way a typical breast cancer person should be treated with. There's no uniqueness to the Lynch syndrome except for the high risk of the other cancers that should be screened for and potentially preventively operated on. I'm just going over the questions to make sure I didn't miss anybody's question. To go back to a question that Jessica asked about the ERSO or ERSO, I am not really aware of that medication, and she mentioned that it is not in clinical trials yet. So I'm really not aware of it, so I would not be able to answer your question, but I'm happy to connect with you on OncoPower later on if this becomes a real thing and we would be offering it to our patients.
This is great, Dr. T. We really appreciate you taking the time to go through all of the questions for our participants.
It's my pleasure. I hope it's helpful, and I'm glad I can.
It looks like we have a new question.
Yes. New message. Yes, very good question. I think Jessica again asked us if a patient or a person who has Lynch syndrome benefit from Lynparza. So Lynparza is one of the medications that are available for a different condition. It's a PARP inhibitor. You might have heard of PARP inhibitors that are indicated in patients who have BRCA positive cancers. And not just breast cancer, now it's approved in a lot of different cancers related to the BRCA gene. It is not something that is indicated in Lynch syndrome because the genetic abnormality and the deficit that those cancer cells have in the DNA repair mechanisms, that's what Lynparza and its family of drugs target, the DNA repair genes. And the deficiency is different in Lynch syndrome, and therefore the Lynparza and the PARP inhibitors are not indicated in that situation. Now I understand why you asked about a medication for Lynch syndrome. You were thinking the PARP inhibitors, but those are unique to the BRCA mutations and similar mutations to the BRCA that are in the same pathway, affect the same DNA repair areas of the gene. And it's, for example, the ATM mutation can respond to that, and probably 2 mutations can respond to the PARP inhibitors. But the highest responses are for the BRCA genes, not for the Lynch syndrome. Are there any way you could explain the Pdl1? Mine came back positive. My tumor is also chemo-resistant, so we started immunotherapy from Crystal. It's a very good topic, the Pdl1. So for the last few years, immunotherapy has been very popular in a lot of different cancers. It has been approved in, I think, 80 different indications. But breast cancer has also been part of those success stories, specifically the triple-negative breast cancer. We have an approval for using immunotherapy in a stage 4 triple-negative breast cancers, but more recently in the early stage triple-negative breast cancers before surgery and for up to 9 treatments after surgery. So the specific one that is approved, so I want to explain, I think Crystal wants to understand maybe how it works and what's the benefit. So Pdl1 antibodies, they're really antibodies. What they do is they try to alert the immune system and recruit the immune cells and teach them that these cells here are cancerous, the cancer cells, they are foreign bodies and you need to attack them. If you could think of the cancer cells are just our normal cells, but they have changed a little bit. And some of them change a lot, some of them change a little bit, but most of them are not detected by our immune system as a foreign body. The same way our immune system will detect a bacteria or a virus or something and goes and attacks it, it detects the cancer cells as just another normal cell of the body and it leaves it alone. So the Pdl1 antibodies, the immune therapies available today, this type of immunotherapy called the checkpoint inhibitors, they go and remove that disguise that the cancer cells have as normal cells and expose them as the bad guy to the immune system. And the immune system, therefore, will hopefully, a good percentage of the cases will attack them successfully. And the good news about immunotherapies, and when they work in some of our patients, majority of the time they will work for substantial amount of time. We could sometimes speak about cure in stage 4 patients who would never heard of before. We have seen some amazing situations when chemo resistance after chemo resistance after chemo resistance, and then the Pdl1 antibodies came up and we like, okay, we have no other choices. Let's try them in somebody who has Pdl1 receptor positivity. And those patients who have the positive receptors have higher chances of responding intuitively. And then we see that all of a sudden the patient responds. So unfortunately, how common that happens is not as common as we'd like it to be. Sometimes it's between 15 to 25% of the overall people could respond. However, some responses can be very successful. Also, the other good thing about them is they don't really have the usual side effects that our patients have struggled with from chemotherapy, meaning if somebody has already had a lot of chemo and have a lot of side effects, this changes completely because the side effects of the immunotherapy are very different than the side effect of the chemo. So there's no additional like neuropathy on top of neuropathy, or does not cause the hair loss. So it would be a little bit of a change. It's not without side effects, but they are very different and they're not as common. So immunotherapy in triple-negative breast cancer is really a success story, both in early stage, it increases the chances of cures, but also in the metastatic disease where it can be used with chemotherapy at first, and then the chemotherapy stops, and then the immunotherapy continues in those who respond well to it. So for our patient here, our question was, yes, Crystal. So I hope that you will really be one of those really super responders to the immunotherapy, and your outcome will be excellent. I really wish you the best, and I would love to hear from you again about your outcome. another question. I think this one is a lymphoma question, diffuse large B-cell lymphoma. It is really not a breast cancer question. I would love to support you outside of this platform, since this is a breast cancer question and answers, but you can ask the question in a private platform in the same site if you don't mind. So our same patient who asked about the ovarian cancer is following up with another question. MMT ovarian cancer stage 3A, I forgot to say that I'm just having last round of chemo next week already. Had full hysterectomy, skipped, and everything removed. I will start a meta prevention soon. I am not clear on the fact that things were removed and chemo has been done and scans are clear. Why do they say the cancer is not curable but controllable? Okay. No, Tammy, MMT ovarian cancer stage 3 is curable situation. However, 1, 2, 3, 4, the higher the stage, the percentages of cures go down by stage. So the stage 4 is considered incurable today, but I'm just saying now, but there are some cures still based on immunotherapy responses in some situations, but in general, stage 4 is considered incurable. 1 to 3, curable. However, the percentages of cures decrease as we go up on a stage. MMT ovarian cancer is a histology, meaning the subtype of ovarian cancer that is a poor prognosis overall, even though in early stages. And in ovarian cancer, we have the PARP inhibitors have been really standard of care, whether the patient has a BRCA mutation or not. They have shown a very good benefit in a maintenance strategy after surgery and after the chemotherapy has been completed. A maintenance strategy with the PARP inhibitors is now standard of care in ovarian cancer. Now, I know this is an ovarian cancer question, but it is involving the PARP inhibitors. I believe that's what the doctor is intending to give Tammy a pill to prevent a recurrence. So when we say, we're giving you did very well, your cancer is all removed. So this is really general question. All the patients struggle with, everybody struggles with this. So my cancer was placed in the ovary or the breast or any part of the body. We took it out with surgery. Why do I need all this stuff? The cancer is removed. So now I want to explain something. The cancer, think of the cancer before it's removed. It's sitting in any organ of the body. It has all the blood flow and all the lymphatics going through it. It is really what we're trying to treat after removing the cancer isn't the cancer that was already removed. We're trying to treat any microscopic cells that might have hopped on the bloodstream or the lymphatic circulation while the tumor was still in the original spot before it was removed. Some microscopic cells can travel and go into the bloodstream and then go somewhere. You may not see them today. You may not see them by our current strategies, which is CAT scans, PET scans. You may not see those microscopic cells because we don't have a microscope inside the bloodstream to look for them. So, but they can either die after the surgery because of the chemo, and that's the purpose of the chemo, or they can hide somewhere. And then 5, 10 years later, 2 years later, they can show up either in the lung or the liver or the bones or the brain or anywhere in the body. So that's the purpose of all the systemic treatments the oncologists give after removing the cancer, or sometimes before removing the cancer. The intention is not necessarily to kill the cancer itself, because that's going to be removed with surgery. It's to kill those floaters. I call them the floaters that travel in the bloodstream that we can't see. So the doctors don't know if you have them, and they don't know if the treatment is killing them because they are microscopic. But we know from doing studies on large populations of patients that those patients who have received treatment after surgery had higher cure rates than those who did not. And that tells us that the treatment we give kills those microscopic cells in a good percentage of the patients, at least good enough to lead to this treatment becoming standard of care. And that's why after doing surgery, we get chemo, and sometimes we get this maintenance protocol. I encourage my patient, I tell them, it's a good thing to have that maintenance as a safety blanket or as a shield from having that recurrence. If it's effective, it is keeping any microscopic cells dormant, maybe killing them. And it will increase the chances of never seeing the recurrence from this cancer. Hopefully this explained Tammy's question. And then there is another one. Do you foresee a place for immunotherapy, hormone positive, HER2 low breast cancer? Very good question. So far, these results of her immunotherapy in ER positive breast cancer was not very high. The numbers were too low to be encouraging or becoming a standard of care. That being said, it wasn't zero. There still are some ER positive patients who still responded to immunotherapy. So a lot of research is ongoing to try to find, how do we find those who will be responding? How do we, are there any biomarkers? Are there any features of those ER positive breast cancers or HER2 low, which is now a new terminology we're gonna be getting used to? Can we find the patients who would be responding to immunotherapy? Now, there's encouraging information about HER2 positive and immunotherapy. It really was encouraging in studies in gastric cancer. Gastric cancer can be HER2 positive also. And they found that combining chemotherapy with Herceptin and adding in immunotherapy really showed some great results. So maybe in HER2 positive breast cancer, the immunotherapy may be a thing of the near future. In ER positive, the researchers are still looking for biomarkers to try to find those amongst the ER positive breast cancers that have potential of responding and not just treating everyone. And when they did that, the responses were low, not high enough to justify the potential side effects at this time.
I think that's all of the live questions we have coming in for now. If anyone wants to continue to submit, we'll keep an eye on the chat. But Dr. T, I'd love your take on some of what's happening in healthcare in terms of telehealth and digital tools and even just drug development and whatnot in oncology, and you know, what tools you have in the toolbox for seeing your patients.
I'm sorry, is that a question?
Yeah, just sort of a commentary on, you know, what you are seeing in oncology care and in healthcare right now in terms of digital health and telehealth, as well as the, you know, just the sheer amount of treatments and drugs that are coming out to help these patients.
Yes, really, oncology has exploded. Just I did my fellowship between 2004 and 2007. And just between then and now, it is a completely different field. In every single subtype of cancer, it is becoming very difficult to be the expert in every single type of cancer because the literature and the new drugs and the approvals are really very fast and happening very quickly. It's very good for our patients. It's excellent. We are so excited to see new options in every single cancer subtype of breast cancer or other areas. So the development, drug development is really very encouraging. There are also new things in the way we monitor our patients, hopefully to change and improve upon what we have today. In terms of this remote access that patients have really benefited from, I found it to be really one of the few positive things from the pandemic is we have learned how to manage the distance and how to offer care, advice, follow-ups remotely. I feel like oncology is one of the fields that is very amenable to remote care, second opinions, just having advice, because it really depends on reviewing the records and just giving an opinion. So I do a lot of this with my own clinic patients. If they are traveling patients from far away and they just need to check in some side effects with me, we can do a visit remotely like this. And it feels very natural. It feels, we feel the connection through the video call. And also in people internationally. I mean, the international reach we can have in giving patients reassurance, second opinions, advice. We can advise patients, we can advise their doctors, they can connect with us while they're in the doctor's visit to have a discussion. It is the era of patient-centered care. It's all about our patients. We don't just prescribe things and tell them what to do. We have a discussion about the options, and we explain to them why we recommend our recommendation and what's the data, and having really that collaboration with the local doctors the patients have or with the patients directly, I think is huge positive. And I'm excited about the international patients as well, because there is discrepancies, unfortunately, amongst the whole world in how things are done, and access for the worldwide patients to care or to the new drugs is not really uniform. And having increasing the awareness of what's going on in the world and what's going on here, what's the new things to patients all over the world, will help increase the access to these people. And maybe they will have advocacy groups say, listen, these patients in this country are getting immunotherapy for this cancer. We don't have access to it. And being aware of what's going on is really, information is always powerful, and it increases the education of the patients and the people affected with cancer.
Absolutely. So we don't have any further questions coming through.
Question. Jessica has been really a great participant, unless there are too many, a lot of Jessicas, but I think it's the same person. Thank you, Jessica, very much for your participation. It really kept the discussion going. Have you ever seen a stage 4 cancer patient cured? Absolutely, I have. I really wish I could have some of my cured patients on this forum right now to talk to and give some encouraging messages to our other patients. But I have had seen some patients who, one of them I can think of because they're really just a very amazing story, who have been with me for a very long time with triple negative breast cancer, who had multiple lines of therapy. I believe we had up to 9 different lines of different chemos over the years. And every time the cancer comes back, give us a short-term benefit, and then it recurs, everything we give. But I believe those lines of therapies have allowed us to stay around until the immunotherapy came out, and it was still very, very early. It had already only been approved in melanoma at that time. So we used it because we had no other choices, and the person was still very strong and healthy and still wanted to keep trying. So we had a compassionate use access. We obtained immunotherapy to her, and she had an incredible response. I think now we are 4 or 5 years without any evidence of disease. And we have stopped the immunotherapy after using it for 2 to 3 years. And then she's still disease free. And I really strongly believe that she's done with this cancer and that she will never hear from it again, and she's cured. I have another one who had metastases in the sternum that was uncomfortable, painful. We treated it with radiation, we treated it with other treatments, and we had some resistance and recurrence. So she did not have a lot of treatment. This one, she had only maybe 1 or 2 different lines of therapy, and she did not tolerate the treatment at all. And then we had the immunotherapy, and she even had side effects from that, but she ended up receiving at least 3 or 4 treatments. And then so far, maybe also 4 or 5 years later, and there is no evidence of disease. This is unfortunately not very common, but it can happen. It makes it worthwhile to give it a try in the triple negative breast cancer. And that's why it got approved, because we have seen cures. It's hard to call it cure because it's still early. It's still only a few years. Even the patients who are treated first in the clinical trials or even off-label use are only now about 5 to 6 years after. But still, it is a long-term benefit that we have not seen before on the standard chemotherapies. A question from Tony: can you take CBD and Verzenio at the same time? I mean, I'm not really very knowledgeable about the use of CBD. There's some good naturopathic people out there that can help our patients with interactions, but I personally don't see any overlap there in terms of any overlap in why wouldn't they work together, or why would they be any toxicities of the two together. But I don't claim to be expert on this. Next question: triple negative breast cancer, if it does return, where in the body does this type of cancer typically return? Janet, as I mentioned earlier, when the cancer returns, it really doesn't really go away. It never went away. Microscopic cells have survived in the body, meaning they had escaped from the original tumor before it was removed, and they go through the bloodstream. And since the blood flows in every part of the body, any recurrence anywhere in the body where the blood goes is a possibility. That being said, the common ones we see are triple negative disease tends to go to the organs as opposed to the ER positive, where it commonly goes in the bones first. So I've seen triple negative patients with lung and liver metastases at the same time, lung or liver, pleural effusion, which is a lining around the lungs that can accumulate some fluid. Another location is the brain. It's not an uncommon. A HER2 positive breast cancer is the number one that goes into the brain more commonly than the others, but I've seen it not infrequently in triple negative patients. So we call it typically bone-only metastases, which is more common in estrogen receptor positive cancers. And we have visceral disease when it's in the organs like the lungs and the liver, the lymph nodes, or the brain. I've seen it in the skin, superficial skin metastases, nodules, typically in the chest area, but it can be also in the back or other areas. But in the chest wall and on the surface of the skin is another location that we see not uncommonly. But again, anywhere where the blood flows, microscopic cells can go and metastasize.
All the
Jessica?
questions that we.
Jessica, where are you? Any questions?
Yeah. Yeah. Well, Dr. T, thank you so much for your time and expertise today. It has been such a pleasure to be able to get your insight on all of these questions.
Oh, you're welcome. Anytime. I think Tony asked a question about some natural remedies that are out there. I don't have expertise in these things, to be honest. And I really rely on my natural specialist colleagues to help with these questions. But I have not personally seen anybody cured successfully with anything outside of the conventional oncology treatments.
Well said. All right. Well, thank you everyone for joining our first Ask a Doc Live. We want to thank Dr. T again for her time and expertise, and we look forward to many more sessions with a variety of specialists so that we can sort of keep this expertise coming at you. Thank you so much, and everyone have a great weekend.
Thank you.